Hello, everybody. My name is Dr. Rafi Rafali, and I'm a resident at Kaiser Permanente in Los Angeles, future neuroradiology fellow at UCLA. And today we're going to have our grounds round lecture by Dr. Leonard Freeman, who is a professor emeritus of radiology and chair of nuclear medicine at the Montefiore Medical Center. Today, Dr. Freeman is going to cover the topic of VQ imaging for the detection of pulmonary embolism. And during the talk, we can have everyone, whenever if you have questions, you can go into the Q&A box, go ahead and write your questions in there. At the end of the conference, we'll have about 10 to 15 minutes to cover some of your questions. And in the meantime, I'll pass it over to Dr. Freeman. Thank you for coming on to give us our Grand Rounds lecture today.
Thank you, Ravi. As you see from this first slide, this is actually a talk that I have put together as a basic talk on ventilation perfusion lung scanning for pulmonary embolism. And I have given this annually for a number of years at the Society of Nuclear Medicine meeting, which usually held in June. Of course, the last couple of years it's been virtual. But I'm planning to start with real basics on the disease itself and then proceed from that portion and hopefully leave enough time at the end for some questions. Okay, I always like to show the picture of these three gentlemen. Dr. George Taplin, who was at UCLA. Dr. Taplin's the gentleman who actually derived the concept of using macroaggregated albumin for performing lung scans. And Drs. Henry Wagner at Johns Hopkins and Dr. Jim Quinn at Bowman Gray at the time and Wake Forest were the two who first actually used it in humans. So let's talk about the disease itself first. You know, pulmonary emboli, 90 to 95% of pulmonary emboli originate in the lower extremities. And from the lower extremities, of course, they get propelled into the central circulation if they break off. And where they lodge as far as the lungs are concerned and what pulmonary arteries depends upon their size. Fortunately, the vast majority of pulmonary emboli are subsegmental in distribution. As they get bigger, of course, you can basically have a segmental type of embolus, such as you have right up here. From that point, of course, you can involve a whole lobe, and much less commonly, you can have an entire lung involved. It's unusual, but it certainly can happen. And of course, you hope you never deal with the catastrophic situation of a saddle embolus, which could, of course, lead to instant death. Well, let's take a quick look and quick review of a blood gas exchange as far as the lung is concerned. You know, here's the pulmonary artery coming in blue, and here you see the gas exchange at the alveolar level. Okay, that right down over here. And then, of course, the pulmonary veins going back to the heart. If an embolus occurs, you can see what it's done. It's shut down the pulmonary circulation, you know, in the distribution of that vessel. But we have a second circulation in the lungs, which of course is the bronchial circulation. And the bronchial circulation, which comes off the aorta, basically maintains the integrity of the airways so that the airways remain patent because of its supply of the bronchial artery allowing that, even though the pulmonary artery itself is shut down. So when we do a lung scan, and I'll be talking a lot about this, of course, we do a perfusion and ventilation study, which you're looking at. And the perfusion study, which is looking at the blood flow, of course, in this particular case, is showing a defect. And it's associated, as you see, with normal ventilation in the area. So this is called a mismatch. And the mismatch between perfusion and ventilation is what detects or determines that the patient does have a pulmonary embolism. Now, in about 10% of the population, the bronchial circulation fails. It is not adequate to keep the airways nourished. And therefore, what happens, as you see here, is the patient that's got a pulmonary embolus in the blood vessel. And here you see you get collapse of the alveoli, you lose surfactant, you get pneumoconstriction, and the diminished ventilation space. And eventually this can lead on to alveolar congestion. You can start to get pleural effusions and things like that on the x-ray. And as I said, this only happens in about 10% of the cases. In 90% of the cases, the bronchial circulation is adequate to keep the lungs nourished, even though the pulmonary embolus is present. So basically, if you look at the green pathway, okay, the embolus lodges, it resolves or fragments, and you get a shifting pattern as you monitor the patient along. And eventually, in the vast majority of cases, it resolves, hopefully, in most cases with the help of anticoagulation. In the 10% of the cases that you see on the right side, where you proceed to pneumoconstriction and atelectasis, this is where you proceed and have an infarct. So, of course, keep in mind the difference between a pulmonary embolus and a pulmonary infarct, with the latter being where the ventilation, the bronchial circulation fails. Okay, so let's look first at the perfusion study. We use particles of albumin, okay? This is an older slide where originally when we started doing this, we used albumin microspheres, but nowadays pretty much macroaggregated albumin, which we call MAA, is the choice of what we use as far as performing these perfusion lung scans. And here you see a schematic of the pulmonary tree as well. And you can see that depending upon the size of these particles, depends upon where it will lodge in the pulmonary arterial tree. For instance, here's a particle that's 20 micra that's going to get blocked and cause an embolus. Here you have particles that are much smaller, 3 micra. They're going to get through and get into the central circulation. They're not going to cause any problem. So what is our average scanning dose? Well, the average scanning dose, as you see, is about 1 million particles. And we usually put this, inject this in 3 to 5 millicuries, and the dose to the lung is very small. Now, those million particles sound like a lot. It sounds like you're giving the patient, pulmonary emboli. But have a look at this. How many capillaries do we have in the lung? See, each lobe and segment of the adult lung is supplied by a discrete artery, vein, and bronchus, which arborize into an incredible network. The terminal arterioles, which represent the 28th branching of the pulmonary arteries, leads to 280 billion capillaries. So you can see if we're giving the patient 1 million particles and the patient's got 280 billion capillary beds, we're not causing any problems. We're blocking a very tiny fraction of the patient's pulmonary artery bed. So if you follow this along, you can see here's an injection given in the arm. And as you can see, it goes into the right side of the heart. It goes over here, I should say, into the right side of the heart. It then goes into the pulmonary arteries, and it gets stuck in the lungs. As you see here, it doesn't go any further because it's blocked, as we said. Sometimes you get what we call radioactive pulmonary emboli. These are large particles. This usually happens if you inject a patient and after you've drawn the blood back into the syringe, you actually lose the vessel. So what happens is you have to find a new vessel. In the meantime, the blood that has been drawn back into the syringe with the macroaggregated albumin that's in the syringe coagulates and causes larger particles. So when you finally do get to inject it, you can see these hot spots throughout the lung are actually just larger particles that have been congealed in the syringe because of the difficulty with the injection, and they're being blocked in much larger portions of the arterial tree. But still, with the factor I gave you, with the billions of capillary beds we have in our lung, it's still not a problem. Just messes up your interpretation. That's about it. Okay, the instrument we use is usually a large field of view gamma camera, and we generally take 8 views. Since they're dual-headed cameras, we usually do 2 at a time. We do the anterior and posterior together, the 2 laterals, LAO and RPO, etc. And we get a full 8-view image. And if you look at the images, you can see there's very uniform uptake throughout the lungs: RPO, right lateral, RAO, anterior. LAO, left lateral, left posterior, blank, and posterior. So you get nice uniform distribution, throughout the lungs, okay? Here's a patient with pulmonary emboli, because what you're seeing here is something quite different. You're seeing all the defects where the particles were unable to get there because of the clots that were blocking it. So this is a perfusion scan showing you what appears to be multiple pulmonary emboli. Now, what about the ventilation study? Well, over the years, there have been multiple agents that have been used, most popularly in the United States, probably xenon gas and technetium DTPA aerosol. Most of you around the world have had access to Technogas, and as crazy as it sounds, the United States FDA to this very day, this is going on. This has been going on for 25, 30 years, believe me. But Technogas, which is usually the universal agent used throughout the world, is not yet approved by the Federal Drug Administration in New York. So a DTPA aerosol and xenon gas are the two that are generally used. Well, xenon gas has got a 5.2 day half-life. Its gamma you see is 81 keV. And we have the patient take a breath. We do this through a spirometer. The patient breathes in. We take a study during equilibrium, and we then do washout images. And here you see just a picture of the type of apparatus that can be used. Here's wash in, WI, wash in, equilibrium, and then wash out, okay? Now the energy, I should point this out also, the energy of the xenon gas is 81 keV. The energy of the technetium MAA that we use is 140 keV. You always start with a lower energy because the lower energy does not interfere with a subsequent study being done with a higher energy. So with the xenon gas, we do that first. Have a look here. Here you see on top a perfectly normal perfusion study and a normal ventilation study. Wash in, equilibrium, wash out. This is a normal study. Down here, here's a perfusion study showing multiple defects down in B with a normal ventilation study. So this, of course, is a patient with pulmonary emboli. DTPA aerosol is what we have used for a good portion of the time. This is taking a technetium compound. This is actually a kidney agent, DTPA, but we use it as an aerosol. And we have the patient breathe it in. And we only use, only a very tiny amount gets into the lung. So you can see on the bottom, inefficient system, and only a half a millicurie of the administered dose remains in the lung. So we can do a ventilation study, and even though it's the same energy, the same technetium as we use for technetium DTP, technetium MAA, in other words, the energy of technetium is 140 keV. The fact that we only get a half a millicurie in the lung, and we can overpower that with 4 millicuries that go fully into the lung, we still are able to get a good ventilation perfusion lung scan. Here's an example of the patient breathing in the particles into the lung. And here you see a normal ventilation perfusion lung scan with matched images. The ventilation images are on the bottom, the perfusion images are on the top. Some people like it in white on black. So here you see the same thing. Normal perfusion study on the bottom, normal ventilation study on the top, all views, and the normal chest x-ray, of course. Chest x-ray is a key part of every examination as well, and I'll get into that in more detail also. Here you see a perfusion study on the bottom showing multiple defects. Q is perfusion. Okay, and look what's alongside it on top, the ventilation study, which is pretty normal. This stuff down here is in the GI tract because when the patient breathes in the technetium particles, some of it is swallowed. So some of it does get down to the GI tract also. Now, here's an interesting case. All of the cases I showed you, and I mentioned this briefly, but we want a negative chest x-ray. Well, we want a chest x-ray as close as possible to being negative because that really optimizes the interpretation of the ventilation perfusion lung scan. In this particular case, if you look at the chest x-ray, it's full of a lot of parenchymal disease. Normally, if we were looking at this, we would say, well, just go do a CT scan. We're going to have problems with the VQ scan. In this particular case, the patient did have an allergy to contrast material and could not have a CT scan. So we just had to go ahead and hope for the best. But as you see, there's a lot of defects that are matched throughout both lung fields, okay? And therefore, we had nothing, we couldn't, we sort of stuck here. And this had to be called an indeterminate lung scan. But as I said, we didn't have any choice. We would have preferred with this chest x-ray to have done a CT scan, but we couldn't do that because of the patient's allergy. Okay, so let's look at some elements of lung scan interpretation, some other elements, okay? Back in 1979, Dr. Dan Biello at Mallinckrodt University in St. Louis devised a scheme that most people still to this day use. It's called the probability scheme, okay? In other words, how probable on the basis of the lung scan is it for the patient to have a pulmonary embolism? And what he determined was that to have a high probability scan down on the bottom, you have to have 2 or more mismatches, okay, between the ventilation and perfusion. He called a single mismatch intermediate, and everything less than that was basically going to be a low probability. Probability he determined as being less than 10% likelihood of the patient having pulmonary emboli. And that's an interesting number to remember because that's going to change as I show you over the years as well. So I'm going to pinpoint and look at, the single medium mismatch thing and just show you how some things change. Because this was a retrospective study. Dr. Bello did this with pulmonary angiography, okay? And he did this after the fact and did this as a retrospective study. So of course, anything retrospective or anything scientific deserves a prospective study, and thus was born the PIAPET study, which is the prospective investigation of pulmonary embolism diagnosis. And this was done in the early 1980s by 6 institutions, which you see listed here: Duke, Henry Ford, Michigan, Mass General, Pennsylvania, and Yale. And 75 of these patients, and this was done with pulmonary angiography, because remember, this was done in the early 1980s, and this was before the days of CT scans. So pulmonary angiography was the deciding factor. And there were some basic problems with this study. Because first of all, they didn't do chest x-rays, okay, as a routine. And I told you what the problem was with that, because you could have a lot of patients with abnormal chest x-rays that would mess up your interpretation also. 68% of the patients were inpatients. Well, inpatients are sicker than outpatients, okay? So they're more likely to have positive x-ray findings. And so this resulted in a very unacceptable 44% intermediate or indeterminate result. Well, that's no good. I mean, what good is any scientific study that's got a almost 50%, indeterminate range? So this was a problem. The positive predictive value of a low probability scan was changed to less than 20% from Biello's original 10%. That's no good either, because a clinician has to make a decision as to whether to anticoagulate a patient or not. And the bleeding rate from anticoagulation has been quoted as somewhere about 8% or so. So if you talk about 10% possibility, that's worth a trade-off. But once you start changing from 10% to 20%, then, you're just not sure. It's unacceptably high to justify a clinician's decision to withhold anticoagulation therapy. So basically, even when there was a revised PIAPET study in 1993, this 20%, less than 20% definition of a low probability scan remained. So this was a bugaboo for many, many years. And to this day, people who use probability interpretations, it's still a bit of a problem. The single segmental medium-sized mismatch was changed from Biello's intermediate and made low probability, okay? Well, that's a mistake also. Here you see 10 of 28 patients with this finding had PE. So this was a problem. So there was a new study that was done 3 years later, which was called the revised PIAPET study. And what happened in the revised PIAPET study is that the low probability scan was still kept, in that range of being less than 10%, less than 20%, and that was a problem. So here you see the pioped, here you see the modified pioped. Anyway, well, clinicians reacted rather violently. Clinicians' response: reporting a lung scan pattern as being of low probability is no longer clinically correct. Furthermore, this report is frequently misinterpreted as ruling out pulmonary emboli. Clinical needs are best served by eliminating low or intermediate probability and calling them non-diagnostic. So clinicians were not very happy with this pioped study and what was going on. But there were some good things. This was in the 1980s, and this was one of the very, very early computer-based studies. So a computer base was there that they were able to go back to, and they learned a lot of other important things about how to interpret lung scans. First of all, clinical correlation, okay? And we learned the importance of clinical correlation in patients with or without cardiopulmonary disease. And I would say when a patient is evaluated for pulmonary embolism, the first study is not going to be a VQ or CT scan. First study is going to be a clinical evaluation and whether or not the patient has, any underlying cardiopulmonary disease. And a determination of what's called the pretest probability, putting a lot of factors together, which I'll get to. And this, of course, is to some extent what people use as the Wells score. Okay. There are a lot of additional findings we learned about as well, which I'm going to get into as well, which help interpret the lung scan. So, clinical correlation, patient stratification with or without underlying cardiopulmonary disease, pretest probability, and the use of ancillary scintigraphic findings. Okay, so as far as evaluating a patient clinically before you do any studies at all, here's a bunch of cardiac problems, here's a bunch of pulmonary problems, okay? And these are things you want to know about. And you can see that when these were used, if you took a patient, if you had no underlying cardiopulmonary disease, and a patient had one segment, you remember I showed you that one segment, that bounced back and forth. One segment, Biello had called, you remember, intermediate, then they made it low, and then it bounced back to intermediate. Well, you can see here that if one segment is involved, then you have no underlying disease. In this pioped study, in its review, 86% of the patients turned out not to have pulmonary emboli. The lung scan is of greatest positive predictive value or negative predictive value when it supports the clinical impression. Okay? If you have a high probability patient based on clinical findings, the scan alone is 87%. If you put the scan alone plus the pretest probability, you're up to 96%. Low probability, similarly the other way, if the patient from the scan alone has a low probability study, but if you put it together with a negative or low pretest probability, it drops down to 4%. So here is basically what's done at Montefiore, and I'm sure is done at a lot of hospitals right now, okay? If you look at the left, what are you looking at? You're looking at, the screening, the pre-op screening, or the pre-procedure screening, I should say. You take a patient with suspected PE, you assess the pretest probability, okay? If the pretest probability is low, okay, and this is pulmonary embolism criteria, basically low. If you look at the right side, you see the pulmonary embolism rule-out criteria. Age 50, heart rate less than, heart rate greater than 100, heart rate, I should say age greater than 50, heart rate greater than 100, saturated oxygen at room temperature, if they have unilateral rib swelling, hemoptysis. If all these things are negative, okay, these are the pulmonary embolism rule-out criteria. If all these are negative, go back to the chart on the left. Pulmonary embolism rule-out criteria negative, you don't need any study. If a patient's got a low pretest probability and the pulmonary and the PERC criteria, pulmonary embolism rule-out criteria are positive, you do a D-dimer, okay? The D-dimer is negative, you don't need anything. The D-dimer is positive, then you should proceed to do a study. And of course, if the pretest probability is high all the way on the right there, you need an imaging study and you should go on and perform one. Okay, so now if you take that same mismatched defect, the one segmental defect, okay, and you have a high pretest probability, putting these different criteria together, this patient has a pulmonary embolus. So here you changed around completely from what was initially an intermediate type of probability to a basically, what you call it? You end up with a pretest probability of that's high, and a patient has one segmental defect. You can see that that is now called a pulmonary embolus. So a one segmental defect, one good segmental defect, and a patient has a high clinical probability, we call positive. Okay, let's go on to a bunch of ancillary scintigraphic findings, okay? These are other things that help you make a diagnosis of pulmonary embolism. Defects caused by normal structures and artifacts, reversal of blood flow going to the upper lobe as well. You can see that number one, reversal of blood flow, cephalization from lower to upper lobes. When you see more activity in the upper lobes than in the lower lobes, this is generally a reason for pulmonary vascular hypertension, okay? And this is often congestive failure or something like that. The stripe sign, fissure sign, I'm going to go through some of these different findings for you. These are also additional findings that can help you make a diagnosis. Stripe sign, fissure sign, segmental contours, pleural effusions, radiographic densities with mismatched ventilation. I'm going to show you a bunch of these different things as we go along, but these are all ancillary findings that help you make a diagnosis. Okay. So look at this perfusion lung scan. What do you see? You see reversal of flow to the upper lobes, okay? The upper lobes have much greater blood flow than the lower lobes. Okay, what is this? This is pulmonary venous hypertension. This is, excuse me for a second. This is pulmonary venous hypertension, and it can be caused by congestive heart failure or mitral heart disease, okay? So basically, what you're looking at is better activity in the upper lobes than in the lower lobes. So this, keep in mind, is pulmonary venous hypertension. More likely than pulmonary emboli, this is congestive heart failure or mitral heart disease. This is called the stripe sign, okay? If you look at each of these different scans, notice that you have a defect, but notice that the defect is in the body of the lung. It is surrounded by normal parenchyma. These are 6 different cases. All right. A pulmonary embolus must come all the way out to the periphery. It must come out to the pleural surface. So if you can see a stripe sign separating the defect from the periphery, that is not a pulmonary embolus. Okay. Here you see something called the fissure sign. You can see here in the right lung, this is the major fissure coming down. Okay. Now, the fissure is a pleural surface, and technically you could have a pulmonary embolus, but 99 times out of 100, what this represents is fluid. So a fissure sign, seeing the fissure on a lung scan, generally will be pleural fluid and not a pulmonary embolus. Now, this is an interesting finding as well. Here you see a lot of different bands of activity, as you see here, throughout the lung fields, okay? You're not seeing just a major fissure or a minor fissure, you're seeing a lot of bands. It's interesting, this has been described as representing lymphocytic spread of carcinoma. And we have made that diagnosis. It doesn't happen frequently, but we've made the diagnosis on several occasions. Most often, it's usually breast cancer that has lymphocytic spread to the lung. So you see, this does not correspond to fissures. It doesn't look like segmental defects. These are just bands of activity throughout the lung. and is diagnostic usually of lymphangitic spread of carcinoma. Now, if you look here, you can see, I told you, if you have a matching defect in a lung on chest x-ray with defects in the lung scan, usually you'd have to say that that's a non-diagnostic study because you wouldn't know if it was pneumonia or if it was a pulmonary embolism. But one piece of work that was done showed something very interesting. It showed that when you have a pneumonia in the upper or mid lung field, okay, and you have a matching defect in that particular location, such as you see here, that usually is going to be low probability. It's usually not going to be a pulmonary embolism. However, if you have the defect in the lower lung field, if you have a pneumonia in the lower lung field or an infiltrate in the lower lung field, then all bets are off. You know, you can see it's 34% can be pulmonary emboli, so you can't deal with that. But it's helpful at least to have the upper and mid lung fields, a pneumonia with a defect only in that area. The likelihood is that it's not a pulmonary embolism. I'm going to show you something else on this study as well, and I may get back to this in just a moment also. And that is, if you look at the perfusion scan, which is on the left, which is called Q, perfusion scan and ventilation scan, notice that the ventilation scan is worse than the perfusion scan. Well, this is the opposite of what we usually like to see, right? For a pulmonary embolism, we want a perfusion defect and a normal ventilation scan. Well, here you got the opposite. Here the ventilation scan is worse than the perfusion scan. Well, this is called a reverse mismatch, and this is an example of a study that is usually not a pulmonary embolism. So here you got an infiltrate in the upper lung field, and more than that, you've got a reverse mismatch. And this reverse mismatch with the ventilation worse than the perfusion, we can say is not a pulmonary embolism. Okay, this is just another example of reverse mismatches again. Here you see a large pleural effusion. Here you see the perfusion scan, and here you see the vent scan. Notice the vent scan is worse than the perfusion scan. Even though there's a large pleural effusion, this is unlikely to be a pulmonary embolism. By the way, most pulmonary emboli are associated with small rather than large pleural effusions. So a large pleural effusion and a reverse mismatch, ventilation worse than perfusion, we say is not a pulmonary embolism, very unlikely to be a pulmonary embolism. Okay, a whole lung. Well, when a whole lung is missing, such as you see here on this perfusion scan, it could be a pulmonary embolism, but as you see, here's a list. The pulmonary embolism is at the bottom. More often than not, this is a lung cancer or something else that might be benign, but a whole lung missing is less likely to be a pulmonary embolism. Well, a lot of people were very unhappy about the probability of low probability going from 10% to 20%, as I said, because it didn't balance off against the complications from anticoagulating a patient. So Dr. Alex Gottschalk, one of the pioneers also in lung scanning, put together a bunch of these findings that I've just described and created what was called the very low probability, which was less than 10%. And if you look at this chart quickly, these are some of the things I've talked about. Perfusion defects smaller than X-ray, 2 match defects with normal chest X-ray, 1 to 3 small, tiny perfusion defects, solitary triple match, single defect in the mid or upper lung field as opposed to the lower lung field, stripe sign I talked about. So he put all these things together and he called these things very low probability. He wanted to get back to less than 10%. Okay, but what happened in the meantime is CT came along, right? And basically, this was in the mid-1990s. And because of some of the problems with lung scanning, CT grew enormously. So they did a PIOPED-2 study, again, to evaluate how good CT pulmonary angiography was in diagnosing pulmonary emboli. And these are the institutions that were involved. And this surprised everyone because the overall sensitivity of a CT angiogram in diagnosing pulmonary embolism was only 83%. You know, people think of CT angiography as 100%, you know, close to it. It was 83%. And that took out studies that were technically inadequate or uninterpretable. So, you know, if they only saw the first or second branching or whatever. So if you put these back in, the sensitivity fell to 78%. And this is very important. The positive predictive value was only 58% when the clinical probability was low. And in PIAPED 1, the VQ imaging PIAPED, it was 56%. So what I said to you about VQ holds for CT as well. Clinical probability is the single most important thing, and you must evaluate clinical probability before you go on to the interpretation of a VQ scan or a CT scan. Small pulmonary emboli have been fascinating for many, many years, okay? And the question is, when you have small pulmonary emboli, does it require treatment? And basically, as you see on the bottom, Dr. Lawrence Goodman, who's a well-known chest radiologist from Milwaukee, he pointed out that there's considerable belief by many that healthy people often pass small clots from the legs to the lungs, and the lung capillary bed traps the emboli, thereby protecting the systemic circulation. So I'm introducing something new here. The point is that there's strong belief and some proof to some extent that all of us every day pass pulmonary emboli, okay? And the small ones, the capillary beds, the pulmonary capillary beds have a property that other capillary beds in the lungs in the body do not have. They have fibrinolytic activity. They basically can trap these clots and lyse them. So basically, we all pass clots every day, and basically they don't need to be anticoagulated. So there are three small scenarios where even small PEs require anticoagulation. Patients with if a patient's got an inadequate cardiopulmonary reserve, all PEs should be anticoagulated. If a patient's got a DVT, certainly they should be anticoagulated. And if a patient's got recurrent small PE, you don't want to get chronic PE and pulmonary hypertension. So therefore, they should be anticoagulated as well. But the concept I'm introducing now is that most small pulmonary emboli we pass every single day, all of us pass every day, do not need to be anticoagulated. And here's a statement from the American College of Chest Physicians. And look what I've underlined on the bottom. For subsegmental PE and no proximal DVT, we suggest clinical surveillance over anticoagulation. They're telling you right here that the small pulmonary emboli we pass every day do not need to be anticoagulated. Overdiagnosis of disease. Look what I've underlined. Pulmonary embolism is a model phenomenon of overdiagnosis. I don't know how many of you may be aware of this, but keep that in mind. Small pulmonary emboli we pass every day, every one of us, and they don't need to be anticoagulated. Okay. Why have we seen such a use in CT angiography? Well, you know, most nuclear medicine departments in the US are located in radiology, okay? In most other countries, it's an independent department. So basically, this is what the problem is. Sorry. So basically, radiologists in general have a lack of familiarity. I tell our residents that the first thing they're going to, radiology residents, the first thing they're going to lose when they finish their residency and go into practice is nuclear medicine. Because unfortunately, they're just not going to be doing it. Most people are doing CT. And I'm going to add also now, particularly in view of the COVID epidemic that's been going on, people are doing less and less ventilation scans, because you don't want to do that. You don't want to put the technologist at risk or whatever. So you're either doing perfusion studies alone, which are good in many circumstances. I'm going to get into that in just a moment, or you're doing CTs. CT basically has been criticized for two things. Number one, of course, excessive radiation, particularly to the breast. So that has improved in recent years. But number two is the whole question of overdiagnosis, because CT picks up some of those small little things that I just mentioned, and they will be anticoagulated. So CT critics, have said that overdiagnosis is one of the main problems, and of course, concern about radiation to the breast. The manufacturers have made major strides actually in keeping that down, but this has been a problem for many, many years. I'm going to skip through the dosimetric stuff right away because I don't think we have time for it, but the breast irradiation has been a major problem. Now, the pregnant patient, for many, many years, I would say for the last 25 years, we have been doing perfusion alone, okay? And we've been using just a 1 millicurie dose of the macroaggregated albumin as being sufficient to do a perfusion study. And the results have been very, very good. In fact, here's an official document from the American Thoracic Society that came out a few years ago. And what they're saying also, here they're saying in pregnancy, that VQ scan should be done in place of CT scans. But let me show you some of our results here. This is perfusion scans alone, okay? And here's a comparison of 97 patients that had CT and 225 patients that had a low dose perfusion, 1 millicurie. And you can see that the positivity from the CT was 4.1%. The positivity from the perfusion alone was 2.7%. It worked quite well. And as far as the false negatives are concerned, well, here's a positive study, that's quite clear. This is a perfusion alone, and you can see the multiple defects with a negative chest X-ray in a pregnant woman. If we look here at the dose, notice that here's the dose this is LDQ, means low dose perfusion only. 0.16 milligray, okay, CT 20 milligray. You can see a considerable difference between the low dose perfusion study and the CT scan. Okay, availability is also a problem. And we have had nuclear medicine available, for years and years at night. We have a tech that does come in, but most places don't. So in many places, if a study has to be done at night, it's going to be a CT, which is unfortunate, but that's just the way it's been. Anyway, I'm going to skip through this a little quickly. Have a look here. One of the things I've always advocated is that if the patient has a positive CT scan, they should have a baseline VQ. Because I think when you do follow-up scans, you don't want to keep doing CTs on the patient, and that's important. Here you see a patient that, these are perfusion scans on the left, A, and you can see this patient's got a positive perfusion scan, okay? This was a study, look at C, this was done about a year later. If you look at C and if you look at A, they look relatively similar, and I wouldn't know for sure that there was any difference. I wouldn't know if this was just residual clots from the earlier study. But if you look in the middle, you can see that the patient did have an intermediate study as well. And the study number B here definitely is improved compared to study number A, okay? So now I know that in C, the patients had recurrent PE, that these are not residual PE from the original study. So doing serial studies is very easy doing VQs. And I advocate two things. That's number one, every CT. I don't think you want to keep doing CTs on patients. Every CT scan, it's positive, should have a baseline VQ for follow-up. And also, any patient that's got a DVT should have a baseline CT scan, VQ scan as well. Here's a sickle patient. And notice 1205, 06, 07, 09. This was done in the emergency room. Patient kept coming back to the emergency room. Notice they're identical. So we know that these are chronic PE. And the fact that we have all the prior studies, makes it very, very clear that this is the case. Okay. 38% of patients with DVTs have lung scan evidence of asymptomatic PE. So this is why I recommend that all patients with DVTs should have a baseline VQ. They may already have a pulmonary embolism, and you wouldn't know about it. Here you see a patient that's had DVTs, and she was a woman in her 80s, and she was put on anticoagulant therapy. 5 days later, she developed chest pain, and a lung scan was done. And you see it's very strongly positive. I mean, here's the perfusion on the bottom, here's the ventilation on the top. And there was no way of knowing whether or not these PEs occurred before or after she was put on anticoagulation. And unfortunately, she was an elderly woman. They ended up plicating her vena cava because they just weren't sure. If this study had been done as a baseline at the time she had her DVTs, it probably would have saved her having the additional study. Anyway, I'm going to quickly go through some of our stuff. This is stuff that we did at Montefiore starting in 2010, actually. And basic algorithm was getting a chest x-ray. If the patient had no parenchymal disease, proceed on to a VQ scan. If the patient had pleural or parenchymal disease, get a CT. If there was problem with the one, get the other. And you can see that it's making the switch from 06 to 07. You can see that comparing CT scans to VQ scans, they're essentially identical in terms of the positivity and the negative studies and whatever. So, in our hands, we've always seen that, the VQ was certainly as good and in some respects better than the CT scan. But, I will say in the United States, certainly most people will be doing CT as their primary exam. Now, the language of lung scan interpretation is something that we dealt with as well. It's been poorly understood and confusing, this business of probability. So basically, we changed and we said PE positive, PE negative, or indeterminate, okay? We got away from using the terminology of probability. And findings consistent with PE, which is PE positive. If it's discordant with objective clinical assessments, further investigation is needed. If we say no evidence of PE on this study, if the finding is discordant with the objective clinical assessment, further investigation is warranted. In other words, what I'm telling you is clinical evaluation is still the most important thing. Here you see some of our results. And I point out at the bottom, notice the discordance between resident interpretation and attending physicians is 1%. Residents are quite good in terms of interpreting these studies as well. So basically, here we had a situation where in all the CT scans, in the VQ scans, we did PE present 9.2%, non-diagnostic 3.2%, absent 87.6%. Very low false negative rate of only 1.5%. Again, this is the standard interpretation. Now, this was the 6 months before and the 6 months after. We changed from probability to saying just PE present or PE negative, which we call the trinary interpretation. And you can see the 6 months before false negative rate is 1.14%. After we switched over to the new interpretation, 1.5%. So it works pretty well, and it's more understandable to the clinicians, because clinicians still don't understand, many don't understand what low probability means. Something 10%, something 20%, they don't know for sure. But when you say PE present, PE absent, it's very clear. The Society of Nuclear Medicine did an appropriate use criteria, and they looked at all different clinical scenarios and basically said whether or not VQ was indicated a particular thing. This is available from the Society of Nuclear Medicine, and it's been published as well. And I'm not going to have the time, unfortunately, to discuss this right now and go through these different scenarios. But this is an official document, and this document, in fact, as you see, has been accepted by the American College of Emergency Physicians and by several other organizations as well. So the use of probability interpretations is no longer the proper thing to do. We just say PE positive, PE negative, and basically the use of this scenario has been accepted by several, including the American College of Emergency Physicians. It's been accepted by many, many people. I want to finish up, just leave a few minutes for questions. Chronic PE. Well, chronic PE, there's been a lot written about the fact that VQs are better than CTs as far as chronic PE. Despite advances in computer tomography and magnetic resonance imaging, the VQ scan remains the preferred test for screening for chronic thromboembolic disease, and it should be viewed as an initial step in the diagnosis of chronic thromboembolic pulmonary hypertension. So patients that present with pulmonary hypertension, basically the lung scan has been pretty good. This particular paper, as you see, comes from a combination it's an international study, London, Boston, Tokyo, whatever. Here you see a study from Great Britain, okay? VQ SPECT, and I'll talk about SPECT in the question period. VQ SPECT showed thromboembolic disease in 44 patients, but 19 of these patients had no thromboembolism demonstrated by pulmonary angiography. Among these patients, 15 of 19, the majority of these patients basically had negative pulmonary angiograms, okay? And VQ SPECT showed the thromboembolic disease in most of these patients that were not shown on pulmonary angiography. So there's been several studies on this, primarily in Europe, some in the US, that have shown for chronic PE, if you have a patient with pulmonary hypertension, you want to know, whether or not the pulmonary embolism, chronic PE, is the cause of this. And patients who have focal defects on their lung scans basically do not have as high a pulmonary artery pressure as those that have global defects scattered throughout. But again, time is short, so I just can't spend a lot more time on this right now. So what I think I'm going to do, I just want to mention, everything I've shown you is basically planar. Many of you across the world are used to doing SPECT. There's no problem with SPECT. The only problem with SPECT is that I believe it does overdiagnose. And comparative studies that we've done, it's only the small PEs that you see on SPECT that you don't see on the planars. But, most people in the world, including people in Europe, will be using SPECT. And the only caution I want to make is that when you pick up the very, very small PEs on SPECT that you might not pick up on planar, what I'm saying is that make sure that, they should not be anticoagulated unless the patient is symptomatic. Okay, I'm going to stop over here. It's a picture of Manhattan Island in New York, and this was during our big blackout back in 2012. And I think what I'm going to do is stop here and have some time for questions.
Thank you so much, Dr. Freeman, for the lecture. That was very informative. And we have a few questions here that we can go over. Some of them have been answered during the course of the lecture, but one lecture from Samir Kumar Shah is any experience using Doppler of the lower limb to diagnose pulmonary embolism by means of a pulsatile waveform.
I'm sorry, using Doppler, the question was, can you diagnose?
Yeah, could you diagnose a PE via Doppler of the lower limb?
Well, I think you might. I don't have any specific experience with that. What I'm saying is that You can be suspicious, but I think you'd want an imaging study of the lungs, to try and confirm. You might suspect something, but I think you need to confirm it.
Excellent. And then another question from Jerome Nobleza is, what is the role of dual energy CT in the diagnosis of PE?
Well, there are different modalities as far as performing CTs are concerned, and certainly in some people's hands the dual energy might be a preferable way of doing it. The only thing I just wanted to caution you as far as CT is concerned is the concept of overdiagnosis. Okay, and when you have basically those real tiny small ones, you should really think twice. And the pulmonologists are generally pretty savvy with this. You should think twice about whether or not you're going to anticoagulate them. But I presume that dual energy offers certain advantages over the single energy.
Okay, excellent. And then here's a question from Charlene Tang. Is it possible to differentiate CTEPH versus PE on a VQ scan?
What was the first thing? To differentiate what?
Differentiate a CTEPH or chronic thromboembolic chronic.
See, I'm not familiar with the first thing you're saying.
CTEPH is chronic thromboembolic.
CTEPH. Oh, you mean,
yeah, CTEPH.
Is it possible to diagnose whether something is chronic or acute?
Yeah, pretty much.
Yeah, I don't think you can from the VQ scan. I think
prior.
Yeah, I mean, it all depends on what I showed you on the serial images, in terms of having something prior. But if you're doing a first study on a patient, you don't know whether it is, and that's part of the problem, and that's what and I think you need to be particularly careful about those small ones and whether or not you really want to anticoagulate it. But I think you're depending on serial images, to determine whether or not something is acute or chronic. But what I wanted to point out is that it's very hard to compare a CT with a VQ. So this is why I said that if you do a CT scan and you do diagnose a pulmonary embolus, I think it's important to do a baseline VQ, because in the future, I don't think you want to keep doing CTs on the patient. And having a baseline VQ will certainly help you. Just judge what's going on. I showed you some cases like that.
And we have here a kind of a question a couple of people had asked. I guess you did kind of touch upon it during the conference, but what is more sensitive for PE, a CTPA or a VQ scan? So I know that you had touched upon it and kind of comes back and forth, but do you know which one, let's say, is more sensitive for PE, a CTPA or an isotope study?
Well, as I said, for clinically, can we use the distinction here between clinically significant and not clinically significant? And I think from that standpoint, the comparative data that I showed so that VQ definitely held its own as far as being able to diagnose clinically significant PE. I will tell you, frankly, I can't tell you the many thousands of VQs I've done. I, of course, started doing this rather early. I've probably been doing this for 50 years, okay? And I am not aware to this day, with the many thousands of VQs that I've done, of having lost a patient, okay, to a fatal PE. So that's the only information that I can give. Which is more sensitive? Well, the CT may pick up some of the, as I said, our chest radiologist will be the first one to tell you that overdiagnosis is one of the problems with CT. And these are CT advocates. These are people who do loads and loads of CTs every day. We did lose some business, VQ business, certainly as a result of COVID, because we were unable to do ventilation scans for a long period of time. So certainly, if I showed you the number of VQ scans that are being done right now compared to the number of VQ scans being done prior to COVID, you'd see a big difference. for many years, we were doing more VQs than CTs, and everything was working out quite well.
Excellent. And I have a question here, but I'm not exactly sure about it. So let's see. It says lung VQ scans is reduced these days in favor of HR chest, and they would like your views. I'm assuming it's high resolution, maybe chest CT. I'm not sure if that question totally makes sense.
Well, look, CT will pick up more PEs. The question is, the vast majority of those, almost all of them, are not clinically significant. So you can't get away from the concept of what's clinically significant, because I showed you the data, even from the American College of Chest Physicians, that small PE needn't be anticoagulated. So, we're getting back to, again, when you talk about, well, which is more accurate, which has a higher sensitivity, you're going to pick up more PEs probably with the high resolution CT. But the question is, the vast majority are not significant. And as far as our data is concerned, clinically significant PEs are picked up equally well.
Excellent. All right, Dr. Freeman, that looks like it is all the questions for today. Again, I want to thank you for coming in today. And we've had over 78 participants for this conference today in our grand rounds from all over the world. And so I want to thank you again, Dr. Freeman, for providing our grand rounds, and thank you for everyone joining us today.
Right. If anybody wants to get in touch with me, you have my email, right?
Correct. We can.
Yeah, I'm just wondering, well, my email, if anyone wants to ask me any additional questions or speak to me about anything else, my email, lfreeman, we see how I spell my name here, at Montefiore, MONTEFIORE.org. And I'll be glad to try and communicate with you through the email. Okay.
Excellent. Thank you, everyone.
Thank you.
Thank you.
Thank you.